Hello everyone, I am Dr. Surbhi and this is the third part of the lecture series on hypertension. In this video, I'll be discussing the hereditary causes of hypertension. So the hereditary hypertension can be divided into two categories. Number one, the hypertension that is associated with monogenic diseases, and number two, the monogenic hypertension itself. In the first category, various diseases that are controlled by single genes that are called as the monogenic diseases, they can be associated with hypertension as one of the manifestations. These can include neurofibromatosis type 1, tuberous sclerosis complex, autosomal dominant hypertension with brachydactyly, that is also called as the Bilgin-Turin's disease. Fourth is polycystic kidney disease, fifth Turner syndrome, and two rare types, that is the Alagill's arteriohepatic dysplasia and Williams-Buren syndrome. So you should all know a few points about each of these diseases. Considering neurofibromatosis type 1 first, it is associated with three characteristic features: the cafe-olate spots, axillary or groin freckling, and Lisch nodules, which are basically iris hematomas. These are the three characteristic features of neurofibromatosis type 1. Second, we have tuberous sclerosis. As I've mentioned earlier, the other name for tuberous sclerosis is the Bourne-Wells disease. It is characterized by hyperpigmented or hypomelanotic nodules, facial angiofibromas, and Shagreen patch. Okay, let me show you how a Shagreen patch actually looks like. So this is the typical Shagreen patch on the dorsolumbar area found in tuberous sclerosis. Third monogenic disease associated with hypertension is the Bilgin-Turin's disease, which is an autosomal dominant disease associated with short metacarpal bones and short to normal stature. Remember, here only the metacarpal bones are short while the length of the phalanges is normal. Because of its features, the Bilgin-Turin's disease is also called as autosomal dominant hypertension with brachydactyly. This here. So it is associated with short metacarpal bones. The next in list we have polycystic kidney disease, which you must already be knowing. It can be of autosomal dominant and autosomal recessive types and is associated with enlarged palpable kidneys. Next we come to Turner syndrome, as you must already be familiar with, is characterized by sex chromosomes XO. The typical patient of Turner's is a girl with webbed neck, widely spaced nipples, short fourth metacarpal bone, short stature, and short stubby hands and feet. The next two diseases, that is the Alagill's arteriohepatic dysplasia and Williams-Buren syndrome, are rare but nevertheless can rarely show up in your entrance exams. Alagill's arteriohepatic dysplasia is also associated with liver disease leading to jaundice, and also associated with heart disease, primarily occurring as pulmonary stenosis. There is presence of facial dysmorphy and ocular abnormalities as listed here. The Williams-Buren syndrome is associated with facial abnormalities, that is elephant faces, and a short stature, and cardiac abnormalities are present along with the hypertension. Okay, these are the few points you need to know about the various monogenic diseases which are associated with hypertension as one of the features. Now second, we come to the monogenic hypertension. The next subset of hereditary hypertension is the monogenic hypertension. Monogenic, as the name suggests, is due to single gene mutations. And where is the gene mutation occurring? There is a single gene mutation occurring at the adrenal glands or the distal renal tubules and collecting ducts. These are the sites where one gene is mutated. In this diagram, it is shown a cell of the distal renal tubule. On the left side is the luminal side, while the right is the basal side, which is supplied by the renal arteriole. This is the basal side and this is the luminal side. Okay. Now, all the hormones brought through the blood supply at the basal side, see the blood supply is occurring here, and all the hormones that are brought through the blood supply at the basal side act on the distal renal tubule as follows. Aldosterone, which is produced by the adrenal cortex, is brought to the distal renal tubule cell by through the blood supply at the basal side, and they exert a mineralocorticoid effect by acting on the mineralocorticoid receptor. The activation of the mineralocorticoid receptor causes increase in the activity of the epithelial sodium channels and the sodium chloride co-transporter. So, this is how the increased reabsorption of sodium in the distal renal tubule occurs by the action of aldosterone on the mineralocorticoid receptor. Also, to point out here, there is another hormone, cortisol, that is produced in the adrenal cortex. This cortisol also has mineralocorticoid action, and this mineralocorticoid action, it exerts through the activation of mineralocorticoid receptor. Okay, but the cortisol, it is deactivated by the enzyme 11 beta hydroxysteroid dehydrogenase type 2, that is 11 beta HSD type 2. In case of inactivity of enzyme 11 beta HSD type 2, there will be excessive mineralocorticoid action of the cortisol to the cortisol, leading to excessive sodium reabsorption, in turn leading to hypertension. Let me show you a diagram here to make it more clear. So this is the aldosterone that is acting on the mineralocorticoid receptor. The cortisol, it also exerts action on the mineralocorticoid receptor. But this cortisol, which has an action on mineralocorticoid receptor, is deactivated by the enzyme 11 beta hydroxysteroid dehydrogenase type 2 into cortisone. So this deactivation allows no action on mineralocorticoid receptor, and thus excessive activation of mineralocorticoid receptor is avoided. But when this enzyme is deactivated or is absent, then the cortisol will exert its action on the mineralocorticoid receptor, and there will be excessive activation of the MR receptor, of the mineralocorticoid receptor, and then there will be excessive sodium reabsorption at the distal renal tubules and collecting ducts, thus causing hypertension. So this was this was a basic concept behind the monogenic hypertension that occurs through a single gene mutation, which causes excessive sodium reabsorption at the distal renal tubules or collecting ducts. Now, before discussing the various types of monogenic hypertension, let us first know when should one suspect monogenic hypertension. First of all, inherited monogenic hypertension usually have an early onset, that is in the late 20s or 30s, and the hypertension, it tends to be severe, usually not easily controlled by the antihypertensive combinations. Okay, as they have an inherited form, there will be always a family history. There will be severity of hypertension, that is, it is not easily controlled by antihypertensive combinations, and there will be a family history present. So there will be a family history of severe hypertension, that is of early onset, that is in the late 20s or 30s. Okay. In addition to the early onset hypertension, there will be abnormalities in the potassium levels. It may be low or high, along with pH abnormalities, that is presence of either metabolic acidosis or alkalosis. As monogenic hypertension is because of abnormally increased sodium transport, it leads to plasma volume expansion, thus leading to suppression in the renin secretion. So, there will be suppressed renin due to plasma volume expansion. Uric acid reabsorption in the cases is reduced at the proximal convoluted tubule, and thus there will be presence of hypouricemia due to reduced proximal tubular reabsorption. So, to conclude, an early onset hypertension with a positive family history, with presence of abnormalities in pH, with presence of abnormal potassium levels and low uric acid levels point towards the presence of monogenic hypertension. Now, coming to the various types of monogenic hypertension, that is the main forms of monogenic hypertension which are there. So, the classification of monogenic hypertension can be done based on the effect or the mechanisms of increased sodium transport. One, it is induced by mineralocorticoids, and other, it is independent of the mineralocorticoid effect. So increased sodium transport that is induced by a mineralocorticoid effect, that is there is increased sodium transport because of increased action of mineralocorticoids. These include three syndromes or diseases. That is, first is the syndrome of apparent mineralocorticoid excess. Second is the glucocorticoid remediable aldosteronism. And the third is the congenital adrenal hyperplasias type 4 and 5. The second is the increased sodium transport, which is independent of the mineralocorticoid effect. That is, there is no action of mineralocorticoids causing the increased sodium transport. That includes the Liddle syndrome and the Gordon syndrome. So, let me remind you about the action of 11-beta hydroxysteroid dehydrogenase type 2 by looking at the diagram below. Remember, both aldosterone and cortisol, they have an action on the mineralocorticoid receptor. But to avoid the excess mineralocorticoid effect of cortisol on the body, the enzyme 11-beta HSD type 2, that is this enzyme, it converts the cortisol into cortisone. The cortisone doesn't have a mineralocorticoid action, and thus it prevents the excess sodium reabsorption. The excess sodium reabsorption doesn't occur if cortisone is produced. In syndrome of apparent mineralocorticoid excess, there is an inactivating mutation of 11-beta hydroxysteroid dehydrogenase type 2 gene. Therefore, the cortisol, it cannot be deactivated into cortisone. Thus, excess cortisol it forms. There is an excess of cortisol. This increases. Excess cortisol causes excessive activation of the mineralocorticoid receptor, therefore causes increase of sodium reabsorption by the sodium epithelial sodium channels and the sodium chloride cotransporter. There will be an increased sodium reabsorption. Thus, increased sodium reabsorption into the blood causes hypertension. Okay. Point to remember, apart from the gene mutation, enzyme 11-beta hydroxysteroid dehydrogenase, it can also be inhibited by this compound carbinoxolone. It is a compound that is found in licorice. Licorice is a sort of a herb that is which has a steroid-like structure. This carbinoxolone has a steroid-like structure. So excessive licorice consumption, which is usually found in candies and commonly used for chewing, this excessive licorice consumption, it inhibits the enzyme 11-beta hydroxysteroid dehydrogenase type 2. Thus, cortisol is increased, and thus it exerts excessive mineralocorticoid action and increased sodium reabsorption, and thus leading to hypertension. Thus, licorice consumption is also a cause of secondary hypertension by inactivation of enzyme 11-beta hydroxysteroid dehydrogenase. Now, coming back to the syndrome of apparent mineralocorticoid excess, the mineralocorticoid action of the cortisol, it leads to excess sodium reabsorption through the epithelial sodium channels and the sodium chloride cotransporter, thus causing the entry of sodium into the lumen, into the distal renal tubule cell, and this sodium, it is exchanged with potassium, which is thrown out into the lumen. Okay, the sodium is reabsorbed through the sodium potassium ATPase pump. Also, it uses hydrogen and throws out hydrogen into the lumen. So, as the potassium and hydrogen is lost, there will be occurrence of hypokalemia and metabolic alkalosis. Also, calcium is lost in the urine, thus causing hypercalciuria, more calcium in the urine. And also, because of deposition of calcium in these tubules, it causes nephrocalcinosis, that is renal stone formation. As sodium reabsorption is increased, there will be plasma volume expansion, thus leading to the suppression of renin and aldosterone, and thus suppression of the RAS, or the renin, angiotensin, aldosterone um, pathway, and thus there will be low renin and aldosterone levels. As cortisol is not converted to cortisone, the 24-hour urinary free cortisol, that is the cortisol to cortisone ratio, it will increase because cortisone is not produced, cortisol is high. The cortisone is not produced, cortisol is high, so free cortisol to cortisone ratio, it's increased. Okay, now what will be the treatment? We have to restrict the sodium. Okay, we have to restrict the sodium. We have to give potassium supplements, as you know, because potassium is lost, hypokalemia is there, so we have to give potassium supplements. Then we can use a mineralocorticoid receptor antagonist for hypertension, which can be spironolactone or eplerenone. Okay, we can also use epithelial sodium channel blockers. So this is the epithelial sodium channel. We can use epithelial sodium channel blockers like amiloride. This will prevent the sodium reabsorption. For the hypercalciuria that is occurring, the excess calcium lost in the urine, we can treat it by thiazides, which decrease the calcium in the urine. Okay, it prevents hypercalciuria. Okay, so this was about the syndrome of apparent mineralocorticoid excess. The next we have glucocorticoid remediable aldosteronism, which is also called as the familial hyperaldosteronism type 1. It is caused by a chimeric hybrid gene mutation that is leading to excess aldosterone action. This is the hybrid gene which causes a gain in function mutation of aldosterone. So you should know very little about this disease, and you just have to know that it is an autosomal dominant form, which came once in the exams. I'll be discussing the question at the last. Okay, so glucocorticoid remediable aldosteronism is because of a gain in function mutation or a chimeric hybrid gene formation leading to excessive action of the aldosterone here. So there will be excessive action of this aldosterone. Excessive action will lead to excessive mineralocorticoid receptor activation. Okay, thus increased sodium reabsorption and leading to hypertension. Remember, glucocorticoid remediable aldosteronism, that is also called as familial hyperaldosteronism type 1. It is an autosomal dominant inheritance. So next, coming to the congenital adrenal hyperplasia type 4. So as I have discussed in earlier adrenal gland chapters and lecture series on the adrenal gland, about the congenital adrenal hyperplasias, I'll be discussing just in brief here and the mechanism how they cause hypertension. In this type 4, you should know that in type 4 there is the deficiency of the enzyme 11 beta hydroxylase. So this is the pathway in which the cholesterol, it is converted into the various mineralocorticoids, glucocorticoids and sex steroids in the adrenal cortex. Okay, so 11 beta hydroxylase enzyme, it is catalyzing these steps as shown. This is the steps which are shown. This is the catalytic reaction of the 11 beta hydroxylase. So the congenital adrenal hyperplasia type 4, it is due to the deficiency of the enzyme 11 beta hydroxylase. Okay, you should remember that it is inherited as autosomal recessive inheritance. The apparent mineralocorticoid here is the deoxycortisone and the deoxycortisol. Let me explain you how it is there. The 11 beta hydroxylase, as it is deficient, this step does not occur. So cortisone is not produced, these steps aldosterone is not produced. The only mineralocorticoid here is deoxycorticosterone, and cortisol is also not produced. Deoxycortisol is also the only mineralocorticoid. But you should remember that deoxycorticosterone and deoxycortisol, these are very potent, very potent mineralocorticoids. Okay, these have a mineralocorticoid action even more than aldosterone and cortisol. These are very potent. Okay, so they cause excessive mineralocorticoid receptor activation. The mineralocorticoid receptor activation is excessive because of the deoxycortisone and the deoxycortisol and deoxycorticosterone. Okay, because of excessive mineralocorticoid activation, because of the high potency of these mineralocorticoids, these cause excessive mineralocorticoid action. Because of excessive action, potassium will be lost, H positive will be lost, as I have already discussed. When there is excess mineralocorticoid action, potassium is thrown out in exchange to sodium. Okay, and hydrogen is lost in exchange to sodium. Sodium reabsorbed, potassium and hydrogen lost, leading to hypokalemia and metabolic alkalosis. Also, because of excess sodium reabsorption, there will be plasma volume expansion. Plasma volume expansion will lead to inactivation of the renin angiotensin aldosterone system, and thus leading to low renin and low aldosterone production. Aldosterone anyhow will be not produced because of the deficiency. So, because the pathway of the production of aldosterone and cortisol, it is not there, so this progesterone which is there, it is directed towards production of more and more of sex steroids. So androstenedione and testosterone production are increased. These increased sex hormones, they have androgenic action and cause virilization in girls with increased facial hair, acne, etc., and early or precocious puberty in boys. Okay, so there will be presence of virilization in girls and precocious puberty in boys in CAH type 4, along with presence of hypertension, hypokalemia, metabolic alkalosis, low renin, low aldosterone. Okay, also the urinary steroid profile, that is urinary cortisol, will be low. Okay, so what is the treatment? The treatment is we have to replace the cortisol to normalize the ACTH production. Because of the low cortisol, ACTH production is increased here, so it'll cause excessive steroid production. Cortisol replacement is there, it normalizes the ACTH on its own. For excessive mineralocorticoid action, we can use a mineralocorticoid receptor antagonist like spironolactone or eplerenone. So this was about the congenital adrenal hyperplasia type 4, the main features of it. Now we'll be discussing CAH type 5, that is caused by the deficiency of the enzyme 17 alpha hydroxylase. So it is inherited as autosomal recessive disease, and the apparent mineralocorticoid here is deoxycortisone. So remember, in 17 alpha hydroxylase deficiency, this pregnenolone, it will not be converted to the cortisol, and it will not be converted into sex steroids. So this step and this step, it's basically affected. Okay, so main is increase in the production of aldosterone. So the deoxycorticosterone increased corticosterone, and finally increased aldosterone occurs. But as I said, that deoxycorticosterone is the main mineralocorticoid. It has a very, very potent action on the mineralocorticoid receptor. So the apparent mineralocorticoid here is deoxycorticosterone, okay, even more than aldosterone. Because of the increased mineralocorticoid action, the mineralocorticoid action is increased, it will cause increase in the sodium reabsorption, and potassium will become low, hydrogen will become low. So it will be associated with hypokalemia and metabolic alkalosis. Because of increased sodium, there will be plasma volume expansion. Plasma volume expansion occurs, that will cause the the suppression of the RAS. Okay, the angiotensin aldosterone system, and this will cause a low renin and a low aldosterone. Aldosterone will be low, so main mineralocorticoid will be deoxycorticosterone. Because there will be inability to synthesize the cortisol will not be synthesized. Also, there will be a block in the sex steroids. Let me show you how. So this is the main step that is blocked. So this step of cortisol production will be blocked, this steps of sex steroid hormone will be blocked. So what you need to learn here is that the boys, they, in the absence of androgens, their genitalia by default is directed towards formation of the female genitalia. Okay, so if androgens are present, the genitalia in the boys will direct towards formation of male. Okay, and if the androgen is absent, then it will direct towards the formation of female external genitalia. Therefore, in absence of androgens here, the sex steroids androgens are not formed. So boys, they will have ambiguous genitalia, while the females, the androgens are responsible for the development of secondary sexual characters. Therefore, the girls, they will have a delayed sexual development, they'll not develop secondary sexual characters, and also there'll be primary amenorrhea. Okay, now what is the treatment of this? The treatment is, because there is no cortisol production, the cortisol production is not there, so there'll be cortisol replacement we have to do. The sex hormone production is not there, we have to replace the sex hormones. Okay, and because of the hypertension that is occurring because of excessive mineralocorticoid receptor activation, we have to block the mineralocorticoid receptors by a mineralocorticoid receptor antagonist like spironolactone or eplerenone. Okay, so this was about the congenital adrenal hyperplasia type 5. Next, we'll be discussing the syndromes in which there is increased sodium reabsorption, but that is independent of the mineralocorticoid effect. That is, it has its own mechanism of increasing the sodium reabsorption, and no effect of the mineralocorticoids or the mineralocorticoid receptors there. So first is the Little syndrome in this category. Little syndrome is also known as the pseudo hyperaldosteronism. Why pseudo? Because here aldosterone is not high, but it appears as if the aldosterone is high. Okay, the pseudo hypoaldosteronism, because there is sodium reabsorption which is increased in the absence of excess aldosterone action. Okay, or it is independent of the mineralocorticoid effect. Always remember, Little syndrome is inherited in the autosomal dominant fashion. Okay, autosomal dominant. This is one of the questions which appeared a few years back. So you have to remember that Little syndrome is inherited in the autosomal dominant fashion. Okay, so it is because of a gain of function mutation in the epithelial sodium channels. The epithelial sodium channels are the main culprit here. The gene that is controlling these epithelial sodium channels, there's a gain of mutation in this. There will be excessive activity of the epithelial sodium channels, thus causing excessive sodium reabsorption into the blood. Here, it is shown here. So there will be excessive sodium reabsorption to the epithelial sodium channels because of gain of function mutation in the case of Little syndrome, thus causing hypertension. So, as you already know, excessive sodium reabsorption is there in exchange of potassium and hydrogen. So it causes loss of potassium and hydrogen into the lumen in the urine, and thus cause decreased potassium levels in the blood, decreased hydrogen levels in the blood, causing hypokalemia and metabolic alkalosis. Also, calcium is lost in the urine, causing hypercalciuria sometimes. Because of excessive sodium reabsorption, as I've told you, there is plasma volume expansion. Plasma volume expansion occurs. This causes the depression or the decrease in the RAS mechanism, that is the renin angiotensin aldosterone system, and this causes low renin and aldosterone levels. Low renin and low aldosterone levels. Okay, so this was the Little syndrome, which is actually a gain in function mutation in the epithelial sodium channels. Okay, the epithelial sodium channels are the main culprit in Little syndrome. So, what is the treatment now? What is the treatment of Little syndrome? We need to restrict the sodium because there is excess sodium. We need to give a potassium supplement. Remember that the mineralocorticoid receptor here has no action. So in Little syndrome, the MR antagonists, they have no role. Okay, because the Little syndrome, there will be increased sodium reabsorption irrespective or independent of the mineralocorticoid receptor action. So MR antagonists, they will not have any role. However, the drugs that are acting on the epithelial sodium channels, that is epithelial sodium channel blockers like amiloride or triamterene, they do have a role. They are the main drugs that are acting in Little syndrome, and we have to use them. If hypercalciuria is present, we can treat it by thiazides, which decrease the calcium loss in the urine. Okay, so you have to remember that a mutated epithelial sodium channel, it remains open for longer duration in the collecting duct, causing excessive sodium reabsorption. Excessive sodium reabsorption occurs, intravolume expansion occurs, leading to hypertension. So we can treat it with the low sodium diet, or we can use epithelial sodium channel blockers like triamterene and amiloride. Okay, so this was about the Little syndrome. Next we come to Gordon syndrome. Gordon syndrome, you should remember, is the type 2 pseudo hyperaldosteronism. Okay, pseudo hyperaldosteronism type 2. Okay, so it is written wrong. It is hyperaldosteronism, pseudo hyperaldosteronism type 2. It is also called as the familial hyperkalemic hypertension. So this is one of the syndromes of hypertension in which there is presence of hyperkalemia. Another disease that is associated with hyperkalemia as well as hypertension is the renal tubular acidosis type 4. It also has hyperkalemia as well as hypertension. Okay, so this monogenic hypertension syndrome, Gordon syndrome, that is a familial hyperkalemic hypertension. Okay, and also remember, it is also inherited in the autosomal dominant fashion. Uh, because of the gain of function mutation in the WNK1 gene. Also, it can be inherited in autosomal recessive fashion because of the decreased function mutation of the WNK4 gene. Okay, so let me make it more clear to you. The WNK1, it is responsible for opening of the epithelial sodium channels. Okay, while the WNK4 here, it is responsible for the closure, that is the inhibition of the sodium chloride co-transporters. Okay, so as seen here, this WNK4, it is responsible for the closure of the sodium chloride co-transporters. So any increase in the function of WNK1, it will cause excessive opening of the epithelial sodium channels, while any decrease in WNK4 or gain or the decreased function of WNK4 will also cause increased opening of sodium chloride co-transporter because it inhibits. So if inhibition is inhibited, then there will be increased action of the sodium chloride cotransporter. So the in WNK4 mutation, there'll be a decreased function of WNK4 and there'll be the overactive sodium chloride cotransporter channels in the distal convoluted tubules. It will in turn cause excessive sodium and chloride reabsorption with intravascular volume expansion, thus leading to hypertension. So just to summarize, a gain of function mutation in the WNK1 will lead to excessive action of the epithelial sodium channels, thus causing hypertension by increased sodium reabsorption through the epithelial sodium channels. A decreased function mutation in WNK4, here it will cause the inhibition, it'll diminish the inhibition of the sodium chloride cotransporter, thus causing overactive sodium chloride cotransporter channels in the distal convoluted tubules, and thus excessive sodium and chloride reabsorption, thus leading to plasma volume expansion and hypertension. Now, because of decreased potassium excretion from potassium channels in collecting ducts, there is presence of hyperkalemia. Also, because of excessive chloride reabsorption, there will be hyperchloremic metabolic acidosis. The hydrogen is also less lost, and potassium is also lost less. So it causes hyperkalemia and acidosis. Okay, so there will be hyperchloremic metabolic acidosis and hyperkalemia. Hypercalciuria can also occur sometimes because of excessive plasma volume expansion. Plasma volume expansion occurs, so there will be suppression of the RAS, and therefore low renin occurs. But aldosterone may be normal or increased because potassium is high. Low potassium causes aldosterone secretion to thrash out the potassium from our body. Okay. Since reabsorption of sodium is high, so low urinary sodium excretion occurs. So what is the treatment of Gordon syndrome? The thiazide diuretics, they inhibit the sodium chloride cotransporters in the distal convoluted tubules. The main mechanism of thiazide action is the inhibition of the sodium chloride cotransporters. So thiazide diuretics, they inhibit the sodium chloride cotransporters, thus inhibit this excessive sodium chloride reabsorption, thus preventing hypertension. So the treatment of Gordon syndrome is low dose thiazides. So this was about the Gordon syndrome, which is associated with hyperkalemia, and it is associated with hyperchloremic metabolic acidosis. This was the last in my list of the hereditary causes of hypertension. One thing I've not discussed is the early onset hypertension with severe exacerbation in pregnancy. Just remember that it is inherited in the autosomal dominant fashion. The adrenal hyperplasias due to 11 beta hydroxylase deficiency, that is CAH type 4, and due to 17 alpha hydroxylase deficiency, CAH type 5, it is inherited in the autosomal recessive fashion. Okay, I'll just use different colors for autosomal recessive. The adrenal hyperplasia caused by 11 alpha hydroxylase and 17 alpha hydroxylase is because of autosomal recessive. Also, apparent mineralocorticoid excess, syndrome of apparent mineralocorticoid excess is inherited in autosomal recessive fashion. The rest all is inherited in the form of autosomal dominant. The rest all have an autosomal dominant inheritance. So just summarizing the algorithm we have to follow if we suspect a case of monogenic hypertension, that is the patient have an early onset hypertension with abnormalities in potassium and pH, then we have to first check the renin levels. Remember, because monogenic hypertension is because of increased sodium reabsorption. Increased sodium reabsorption causes plasma volume expansion and thus causing inhibition of the RAS system, and therefore the renin levels will be low. Okay. If the renin levels are not low, that is they are high, then we suspect non-monogenic causes, that is renal artery stenosis. Now, if the renin levels they are low, that means we can think of monogenic causes. Okay, now among the monogenic causes, now next we have to check the aldosterone levels. For checking the aldosterone levels, it can be low, it can be normal, it can be high. Okay, so the aldosterone levels, they're usually low if there is either congenital adrenal hyperplasia or apparent mineralocorticoid excess, and they're high if there is familial hyperaldosteronism, that may be glucocorticoid remediable or glucocorticoid resistance. Okay, so first we need to know what is an MRA response. MRA response is the resolution of hypertensive symptoms or normalization of the BP on giving mineralocorticoid receptor antagonists, okay, like spironolactone or eplerenone. So MRA response is mineralocorticoid receptor antagonist response. Always remember that MRA response will only be present when there is increased sodium transport because of the effect of mineralocorticoids. So the syndromes which are independent, which are increasing the sodium transport independent of the mineralocorticoid effect, that is the Liddle syndrome, the Gordon syndrome. These are the two syndromes in which the increased sodium transport is independent of mineralocorticoid response. Therefore, they'll have a negative MRA response. So the Gordon syndrome and the Liddle syndrome, they have a negative MRA response. Okay, so after checking the aldosterone levels, we know that aldosterone level is low. We can suspect either syndrome of apparent mineralocorticoid excess or congenital adrenal hyperplasia. Now, and also Liddle syndrome. Now, we check the MRA response. MRA response, if it is absent, we can say that it is Liddle syndrome. Low aldosterone levels with absent MRA response is Liddle syndrome. But if MRA response is present, that is action of mineralocorticoid receptors is there on the hypertension, we next check the deoxycortisol to cortisol ratio. Remember, the corticosterone or deoxycortisol is increased in CAH. Okay, so the congenital adrenal hyperplasia is the answer when in increased deoxycorticosterone or increased deoxycortisol occurs. If the ratio, that is the deoxycorticosterone to cortisol ratio, is low, we can say it is apparent mineralocorticoid excess. Remember, deoxycorticosterone is only increased in CAH. Okay, so we can say that if it is increased, then it is congenital adrenal hyperplasia, and if it is not increased, then it is the apparent mineralocorticoid excess. Now, if the aldosterone levels are normal and the MRA response is absent, then we can say it is Gordon syndrome. But if the aldosterone levels are high, we can suspect the glucocorticoid remediable or resistant causes of hypertension. So we check the response of two glucocorticoids. If there is response, then we can say it is the glucocorticoid remediable hypertension, that is hyperaldosteronism, that is type 1 familial hyperaldosteronism, and the glucocorticoid resistance is the type 2 familial hyperaldosteronism. So this was the algorithm we follow for the monogenic hypertension. Just ending this topic with one question which appeared in PGI 2009, that monogenic autosomal dominant causes of hypertension are. So remember, CAH, both types, 11 beta hydroxylase and 17 alpha hydroxylase deficiencies, they are autosomal recessive, as well as syndrome of apparent mineralocorticoid excess is recessive. So 17 alpha hydroxylase is autosomal recessive. Gordon syndrome, I told you that there are two forms: autosomal dominant, in which there is WNK, one gene gain of mutation. Okay, so that is autosomal dominant. So it is inherited in autosomal dominant form, right? It can be autosomal recessive also. The pregnancy associated exacerbated hypertension, as I've already discussed in this table, I told you that I've not discussed here, is autosomal dominant. Okay, so it is autosomal dominant. The glucocorticoid responsive hypertension is nothing but the glucocorticoid remediable hyperaldosteronism. That these two are the same things actually. Therefore, the glucocorticoid responsive or remediable hyperaldosteronism, these are autosomal dominant. Okay, for this answer, B, C, D, and E all are the forms of monogenic autosomal dominant causes of hypertension. All right. So this was all about the monogenic hypertension and the hypertension associated with monogenic diseases, together categorized as the hereditary causes of hypertension. In the next lecture, I'll be discussing about the mislabeled hypertension, which includes the white coat hypertension and the masked hypertension. I'll also be discussing about the home BP monitoring and the ambulatory BP monitoring, and also some points on the BP variability and its implications in the next lecture. Thank you.